Well, let's continue. There's nothing we can do. Hmm.
Yeah, 3 months ago, she was in India for 3 weeks to attend a family wedding. She worked, okay, let me start from the beginning. A 79-year-old woman comes to the physician for the evaluation of a 2 month history of a non productive cough and fatigue. During this period, she has also had a 4.5 kg weight loss and has become increasingly short of breath with mild exertion. She has congestive heart failure and hypertension. 3 months ago, she was in India for 3 weeks to attend a family wedding. She worked as a seamstress in a textile factory for 50 years. She has smoked one pack of cigarettes daily for 47 years. Her current medications include enalapril, digoxin, isoniazid, spironolactone, and metoprolol. She appears thin. Her temperature is normal. Pulse is normal. Respirations are 25. Blood pressure is 110/70. Pulse oximetry on room air shows an oxygen saturation of 94%. There is dullness to percussion and decreased breath sounds over the right lung base. The remainder of the examination shows no abnormalities. Lab study shows a glucose level of 90, serum lactate dehydrogenase of 227, and serum protein of 6.3. An X-ray of the chest shows nodular pleural lesions on the right side and a moderate-sized pleural effusion. Thoracocentesis shows 250 ml of turbid fluid. Analysis of the pleural fluid aspirate shows the suture following is most likely underlying cause of this patient's effusion.
Yeah, she has a weight loss. She takes a smoked one pack of cigarettes.
I think we have to calculate this transudative and exudative so that we can know if it's infectious or
It's already
those
exudative.
things.
It's exudative because the lactate hydrogenase is high. Protein, more than half. Protein is more than half. The LDL is already higher. Um, I saw with notes of somewhere, and this patient works in textile industry. Lung cancer.
248 over 227 and just calculate.
She has a cancer. So
Hello?
the nodular
Hello?
flu shows a nodular pleural lesions on the right side and a moderate sized
Hello?
pleural effusion. Yes, we can hear you.
Chief,
Yeah, so I'm saying that if you can identify that this is exudative, so what option are you deleting?
Yeah, we know it's exudative. So there's a finding on the chest is a nodular pleural lesions. So mesothelioma.
Mesothelioma. It's very straightforward. There's no catch. So because of the pleural lesions, yeah. It's a seamstress.
Yes.
People that work with textiles, they also have exposure to asbestos. So
Mm.
um that's that. I just don't know where this stuff stopped. I don't know where it stopped. Let me see. Let me
I think we
see.
should just continue. Like, there's no time.
Yeah, maybe let's continue. Maybe when you have time before you post it, maybe you can find.
Okay, so
We're
pneumothorax,
almost done.
for the pneumothorax, so this is just collection of hair in the pleural space, and you have three types. Um, the primary spontaneous pneumothorax, the secondary, and the tension. So the primary spontaneous occurs in people without any risk factors. They are just tall, thin. They can just have these pleural blebs, that can easily rupture and they can develop pneumothorax because of their configuration. But people with the secondary spontaneous pneumothorax actually have some underlying lung pathology. Most of them are actually cavities, like people with COPDs, people with infection like pneumocystis jirovecii and TB. They are prone to forming cavities, you know. Or if the person underwent a procedure like thoracocentesis, they can easily puncture into the pleural, or maybe the person is they are trying to insert a subclavian line, or the person is on mechanical ventilator and there is barotrauma. You guys remember, hair can easily, you know, leak out of that ruptured alveoli and track to the pleural space, leading to secondary pneumothorax. Then the last is the tension. So tension can occur secondary to any of these initial two. And what tension is just all about is that you have like an entry point of air into the pleural space, and it's a one-way valve that does not allow air to escape. So the hair will keep building up in the pleural space, and it can shift the mediastinum, kinking the vessel like the SVC, the IVC, impeding return of venous blood back into the heart. So there's a form of obstructive shock, and this person is going to be hemodynamically unstable. So how do you know that this person is in tension? Your hemodynamic instability is not enough to tell you that the person is in tension. You have to look out for the evidence of the shifting, like the person having tracheal deviation, right? Tracheal deviation. You see your mediastinal shift, you do your X-ray, there's elevated JVP, there's hypotension, and the likes. But your tracheal deviation will help you clinically, right? Um, if you do your examination of an individual with pneumothorax, don't forget that the presentation is just going to be one-sided, just like pleural effusion, but there's going to be high percussion notes. There's going to be hyperresonance, which is very important. You should not forget that. And jugular venous pressure is going to be elevated due to the compression of the subclavian vessel. So tension is when you have tracheal deviation with what? Hemodynamic instability. So your tension pneumothorax should be made clinically, ideally. And if you do your chest X-ray, just look out for area of hyperlucency. This is an hyperlucent area, and you can see this lung collapse. The hair within the pleural space is not compressing on the lung, so that's why the lung is collapsing in this area. So this is exactly what you have here. This the area of the hyperlucency with the collapsed lung. So how do you treat tension in pneumothorax? For tension, you need to decompress with needle first, then you insert your tube later. Please, can we hear me?
Yes.
Yes.
Okay. You decompress first, put your chest tube later. So that's for tension. But for small pneumothorax that is not symptomatic, just observe and give oxygen. It's going to absorb. For large one that are symptomatic, you might need to put in a small bore chest tube. Most of the time you put a chest tube that is small bore for large. But for patients who are unstable or having recurrent pneumothorax, you have to put in a chest tube proper to continue the drainage. So that's that about pneumothorax. Very easy. No catch. Let's see one or two questions.
Sorry, please. What's the distinguishing feature of for tension pneumothorax?
Yeah, the tracheal deviation and the hemodynamic instability. So you are going to see the tracheal deviation, mentioned in the question stem. That is going to tell you that, oh, there's a tension that is pulling this thing away. So let's see if we can identify one or two stuff. Okay, doctor, over to you.
A 22-year-old man comes to the emergency department due to sudden onset dyspnea 2 hours ago while watching TV. The patient's dyspnea is gradually improving, but he still has sharp right-sided chest pain that is worse with deep inspiration or cough. His medical history is unremarkable. The patient smokes 4 to 5 cigarettes daily and occasionally drinks alcohol. Temperature is normal, blood pressure is normal, pulse is normal, respirations are normal. Pulse oximetry shows 98% on room air. He weighs 68 kg, he is 6 feet 2 and has a BMI of 19.3. Physical examination is unremarkable. Chest X-ray reveals a small right apical pneumothorax. Which of the following is the most appropriate management of this patient? Supplemental oxygen. Wait, mm, no, sorry.
So what are we picking?
That's spontaneous pneumothorax.
Mm-hmm.
And blood pressure over 40 pounds. He's hemodynamically stable. So
Yeah,
uh, just give supplemental oxygen.
it's a small pneumothorax. Just give oxygen. The person is going to be okay.
Mhm.
Okay. There's no
A
catch.
63-year-old man is brought to the emergency department 30 minutes after being involved in a high speed motor vehicle collision. He is obtunded on arrival, he is intubated, and mechanical ventilation is begun. The ventilator is set at an FiO2 of 60%, tidal volume of 440 mils, and PEEP of 7 cm. On the third day of intubation, his temperature is normal, pulse is normal, blood pressure is normal. There are decreased breath sounds over the left lung base. Cardiac examination shows no abnormalities. The abdomen is soft and not distended. ABG shows respiratory alkalosis. Oxygen saturation is 89%. Monitoring shows a sudden increase in the plateau airway pressure. An X-ray of the chest shows deepening of the costophrenic angle on the left side. Which of the following is the most appropriate next step in management?
Hmm. Um, that this patient is being hyperventilated and
Dr. Babali, we can't hear you.
Yeah, I'm leaving the floor for you guys.
Okay.
needle decompression.
Uh,
Why?
Nidu. Why do you want to Nidu?
I don't-
Okay, so why do you want to
So
Nidu?
the pH is 7.49 and PCO2 is low. So probably there is hyperventilation in this version. The mechanical,
So
the mechanical
Dr. Antonia, you know I've
ventilation.
said it. The only time you need
Mm.
to is when. The only time you need to is when there is what? There is
Tension,
Hemodynamic
when there's
tension in,
tension.
stability.
So if there's
Yeah.
no tension, don't need to. Once you cannot pick
okay.
tension, don't need to. So here now, is there anything that
Yes,
suggests you have tension?
no. So we do,
So this is likely to be barotrauma for mechanical ventilation. So
yes,
just insert your chest tube and you leave.
yeah,
So don't forget that about that tension. It's very important.
yeah. The blood pressure is even okay. So
Yeah. Okay. So we have.
hello, Dr. Babawale. He's off again.
Yes.
Hello.
Hello, we can hear you now.
Okay. Okay. So sorry, but it's my mic.
Oh,
Yeah. So uh yeah. So I said obstructive sleep apnea is like a sleep disorder that occurs when you have like a pathology in the upper airway that is causing increased resistance to blood flow to air flow. So there's failure of the upper airway to relax. You know, during sleep, which is causing the sleep apnea. So once the muscles in the um, upper airway lose their tone and they are relaxed, you can have obstruction. So sorry about that, please. I'm so sorry about that. What I mean is the airways, they have some tissues around that airway. If they lose their tone, they will be relaxed and there will be occlusion. The only way there can be patency of the upper airway is when those parapharyngeal muscles contract and their tone increases. That's when you can maintain patency. So if there's anything that reduces the tone of the, this parapharyngeal airway tissue, if there's anything that reduces that tone, they are going to be relaxed and there's going to be obstruction. So people that are obese, they have a lot of fat tissue within the neck, so that already narrows the space within the airway. And people with stroke, because of the reduced neurological stimulation of those muscles, there's a low tone, there's relaxation, there's occlusion. People that are elderly, they have that reduced neurological and muscular tone within the airway, so it can also predispose them to obstructive sleep apnea. People that are of the male sex, so male sex have a lot of muscles within the neck and the torso, so that can also lead to obstructive sleep apnea. People that have craniofacial abnormalities like glossoptosis, having their tongue falling backwards, they can cause obstructive sleep apnea. People with upper airway abnormalities like adenoidal hypertrophy, that's well explanatory. And people with sedatives, people using sedatives like alcohol, benzodiazepine, those sedatives reduce the tone of those airway muscles, leading to the relaxation and the occlusion. So smoking also helps, also worsens, you know, the tone of those muscles and lead to um, obstructive sleep apnea. So if you are trying to do a lifestyle modification, encourage weight loss, encourage smoking cessation. So what are the cardinal features that you are going to be looking out for in the history that was going to raise your suspicion for obstructive sleep apnea? Now, the first is what you call obstructive apnea, hypopneas, or um, respiratory effort related arousal. Now, you might not be able to get this from history. This is going to be examination findings. If you are doing your polysomnography, that's when you can detect your obstructive apneas, hypopneas, and RERA. So what the apnea is just talking about is when you have a complete or about 90% reduction in inspiratory airflow, during sleep. So there is like a 90% reduction in airflow during inspiration, right? Due to any of these stuffs we have talked about. So I think I have like a write up here to just show us what I mean so that we don't get confused. So the apnea is when you have a complete or 90% cessation of inspiratory airflow for 10 seconds. The apopnea is when you have like a 30% reduction from baseline. Your RERA is when you have arousal from sleep due to increased respiratory effort. Just imagine somebody is not able to get in air, right, through the airway. What do you think will happen to the nervous stimulation? They are going to, try to wake up that person. The nervous system is going to fire, wake up the person to hyperventilate so that the person can take in more air. So that's what you call your RERA. So respiratory effort related arousals because of the apnea or the hypopneas. Because of the fact that these guys are going to be having, RERAs from time to time, waking up, the quality of sleep is going to be reduced. So you see them experiencing daytime somnolence. They're sleeping during the day. Everybody sleep at night. They don't sleep at night. They'll be sleeping during the day. They're fatigued. They're tired when they wake up in the morning. Their concentration is very poor. They experience morning headache. All these things are very common. Just picture yourself not sleeping very well for like 5 days. You are going to start experiencing all these things. Then, when they are sleeping, their partners will tell you that they notice that they are snoring, particularly people with the obstructive adenoidal hypertrophy or people with obesity. They snore. Sometimes they gasp for breath because they cannot take in air, so they gasp. They almost choke, and they are restless. So once you are seeing snoring, gasping, choking, it means that there is an occlusion of that airway preventing adequate airflow during inspiration. Now, what you must separate is that this is different from central sleep apnea because um uh how do I put it? You these individuals now they will still have like um uh like excretory movement of the diaphragm. Like they will be trying to breathe, but it's just that the hair. If you are trying to breathe, you have to contract your diaphragm, right? Contract your diaphragm, use your respiratory muscles to get the hair in. Now, when the hair is now trying to enter the airway, it's now encountering a resistance in the airway. Do you understand what I'm saying? Hello?
No, please, can you
Yes.
take it?
So, like, if this is, let me draw. Where's the marker again? So just imagine that this is somebody's mouth. This is somebody's. Oh my God, where is this thing going? So let's just say that this is the mouth, right? When you are breathing, you need your diaphragm to be contracting, right? So in people with obstructive sleep apnea, you see that this diaphragm is contracting. Do you get it? You see the abdominal
Yeah.
movement. Do you understand?
Mhm.
But the hair, they're
Yes.
supposed to be, and all these things you are doing is just to take in hair like this into this part. But when the hair now gets here, this hair is now very narrowed. This place is narrowed. Do you think the hair will be finding it easy to move in? No.
No.
So if air cannot move in, what do you think will happen to the tidal volume? Eh?
It will decrease.
Tidal volume decrease. If tidal volume
Mhm.
decrease, what do you think will happen to ventilation?
Ventilation will
Reduce.
it will reduce.
There's no catch in all these things, oh my people.
It
Eh?
will
It
decrease.
will decrease. Ventilation is tidal volume times respiratory rate. Ventilation
Mm-hmm.
reduce. So that's why they're having problem. But you are still seeing them having their chest and abdominal movement. Do you understand? So
Mm-hmm.
it is because of this that you see them choking, that you see them gasping. Okay, Dr. Antonia, just picture that somebody is holding your neck, you know, pressing on your neck, and you want to breathe. Won't you start choking? Do you
I will
understand?
stroke.
Yeah.
I will,
So that is exactly what is happening to them. So the obesity, the whatever tone that is reduced here is making them choke. But in people with other form of apnea, like maybe central sleep apnea, because the problem is from the brain, they cannot initiate that reflex to coordinate the diaphragmatic expulsion. So you not even see
mm,
them breathing. Do you get what I'm
mm,
saying? So
yes.
that is what you need to know. Now, um, you have to you can use the stop bang survey, right, to separate, to know how you are going to evaluate further. Your S is talking about snoring. Are they snoring? T is talking about tired. Are they tired? O is talking about observed stop in breathing. The P is increased blood pressure. The B is the BMI greater than 35. The A is 50, age greater than 50. The N is the next circumference greater than 40. The G is a male gender. So anybody with 3 or more of these, you have to do a sleep testing, polysomnography. So once you have 3 or more of the stop bank, you have to do your sleep study. But most of the time, the question stem is going to give you everything. So you have to order your sleep study most of the time. But it's good for you to calculate. If you want to calculate, it's good. Just calculate it. Is this person snoring? Is he having BMI greater than 35? Is he age more than 50? They might not give you the next circumference, but they will tell you that the person is a male having elevated blood pressure. You know, just order your polysomnography. So, what are the um, complications? Your cardiovascular comorbidity, like because of the hypoxia, they are going to be having increased sympathetic flow, causing hypertension, pulmonary arterial hypertension, coronary arterial disease, arrhythmia, heart failure, polycythemia, stroke. Very easy. You know the reason why they're having polycythemia? Who knows? It's not. These are not stuff I should be teaching all over. We know this.
From my
Chronic
hypoxia.
Yeah,
hypoxia.
from the hypoxia. Polycythemia can lead to stroke, right?
Mm-hmm.
Heart failure can come from the systemic hypertension or the pulmonary arterial hypertension. Arrhythmias, because of the heart remodeling, they can have arrhythmias. Coronary arterial disease because of sympathetic, discharge, and some of them can also have comorbidity like obesity. So we can worsen the incidence of coronary arterial disease. So because of the obesity, they can have increased risk for type 2 DM and insulin resistance. Because of the fact that they are fatigued, they cannot concentrate, they can have increased risk of accident from the impaired alertness. That is all. It's very simple. So, what's the best next step? Polysomnography. And how do you make your diagnosis? You just calculate the apnea hypopnea index. And how? Once you do your polysomnography is going to show you the number of apnea and the number of hypopnea, and it's going to be divided by the total number of sleep. You don't need to calculate it. They will give you the question. And if it's more than 5 plus symptoms, you can call it obstructive sleep apnea. If it's more than 15 or equal to 15 without symptoms, with or without symptoms, like galley of symptoms, obstructive apnea. So once you get 5 and above with symptoms, obstructive apnea. 15 without symptoms, obstructive apnea. So how do you treat them? Stop smoking, weight loss, encourage weight loss to reduce obesity, tell them to stop smoking, then give them CPAP. CPAP is going to increase the airway pressure, so can reduce the resistance, the occlusion. So don't forget to use CPAP for obstructive sleep apnea. If it's obesity hypoventilation syndrome, you give BiPAP. We'll get there. So CPAP for obstructive sleep apnea, BiPAP for OHS. Don't forget. What other thing can you do? You can put in oral appliances to push the mouth forward, the tongue forward. You can stimulate the apoglossal nerve to push the tongue forward. You can do like a maxillomandibular advancement to put the jaw and the tongue forward. If all these things fail, just go and do your tracheostomy and patient is going to be alright. So, for the obesity hypoventilation syndrome, this is just more like a cause of restrictive lung disease. So, what you are looking for here is just, like two major stuff. Is the person obese? And what is the sign of hypoventilation in this person? Is the person having an awake available hypoventilation? Evidenced by PaCO2 greater than 45. You see, once you look at the question stem and they are telling you that this person has a daytime PaCO2 that is elevated, oh, just know that this is hypoventilation, obesity hypoventilation syndrome. People with obstructive sleep apnea, they have their own problems at night. Once they wake up in the morning, nothing they happen again. They are okay. They just start feeling fatigue, poor concentration, but all these respiratory problems will not be there. But people with obesity hypoventilation syndrome, their own problem persists to the day, and they are going to be having PaCO2 greater than 45 because they are hypoventilating and they are going to be obese. And if you rule out if you try to look for any other cause of the hypercapnia and the hypoventilation, you will not find. It's a diagnosis of exclusion. So, yeah. So now, most of the time, 90% of them is going to have um, um, co-complication with obstructive sleep apnea. So, with the obesity hypoventilation, you are going to be seeing obstructive sleep apnea with them. They have both of them together, right? And sometimes, in 10% of cases, you just see your obesity hypoventilation syndrome with sleep-related hypoventilation. And what do you mean sleep-related hypoventilation? Let me show us what I mean. This is when you have your SpO2 less than 88% for more than 5 minutes with a rise in PaCO2 during sleep. That is sleep-related hypoventilation. So, don't forget this. This is what you need, though. See, this thing looks complex, but trust me, if you know this, you just be like a genius. Obesity, more than 30. Awake, that's what you are looking for. Diurnal, like during the day, alveolar hypoventilation, which is what PaCO2 greater than 45. Don't think about any other thing. This is obesity hypoventilation syndrome. So it is due to
Sorry,
the
Dr. Bobo.
yeah
Oh, sorry. Yeah. I just wanted to add, you said the OHH with sleep-related hypoventilation.
yeah yeah.
Um,
So what's your question
think
then?
that, oh, so they do have the hypoventilation during sleep. Is it not the same thing to ulcer?
No, no, no. I said awake. Do you get it? Awake
Mm.
alveolar hypoventilation. Can you see that I'm already separating it from ulcer?
Yeah, I know. I said the one with sleep-related hypoventilation.
Yeah, yeah, yeah. So what's your question? What's your question with that?
No, I think what we said about that. You said something. Um,
SpO2 less
is
than
it
88 with
okay
PCO2
during
raised.
sleep?
Hello?
Oh, during sleep. During
Yes,
sleep.
during sleep,
Oh,
yes. So
that's what I want.
it's different from your apnea. All these ones is just reduction in inspiratory airflow, for more than 10 seconds. Those ones, it is your machine that would, detect that. You can't detect that. Do you understand, Dr. Antonia? So it's your
Okay.
polysomnography
So
that
you
is.
don't observe apnea in them. You don't observe apnea in them, like during sleep.
In people with, yeah, you can observe apnea with them if they have like co-obstructive sleep apnea. You know that most of the time, that's why they're saying like 90% of them, they are going to have OSA with it.
Mm,
Do you understand?
mm,
But sometimes
mm.
90%, 10% will not have OSA. They will have sleep related hypoventilation. And what do you
Yeah,
define?
that's what I mm.
So,
That's what distinguishes them from people with OSA.
exactly. So, instead of having all those features of OSA, which is what? Your apnea, your apopnea, your RERA, they are going to be having sleep related hypoventilation, which is what? SpO2 less than 88% for 5 minutes with a rise in PCO2 during sleep. Do you understand, Dr. Antonia?
Yes, yes.
So, but don't worry yourself about all these things. This is what you are looking out for. Once you see that, you move. So if a patient has OHS and ulcer, because of the ulcer, just give your CPAP. You will have encouraged weight loss, give your CPAP. But if there is no ulcer, and okay, so before I move, if the CPAP fails, use BiPAP. Now, if the patient has OHS with hypoventilation, just give your BiPAP straight. Your BiPAP will help you with the ventilation. Give your BiPAP. So if your BiPAP fails, you cannot do your bariatric surgery or your tracheostomy as a last resort. Do you understand? So let us look for a question to see if we can figure it out. So let's read this and check it through. Okay, I think I have like two questions. I should have more than two. Okay, but no problem. Let's check them.
A 52-year-old man is brought to the office by his wife. According to her, he repeatedly wakes up at night and seems to be choking but falls back asleep quickly. The patient reports fatigue and often falls asleep while reading books or watching TV. He had childhood asthma that required inhalers. Other medical conditions include type 2 DM, hypertension, and hyperlipidemia. Medications include metformin, stagliptin, atorvastatin, amlodipine, and lisinopril. The patient does not use tobacco and drinks alcohol only on weekends. Blood pressure is high, pulse is normal, BMI is 34. There is no jugular venous distension, lungs are clear to auscultation. A grade 2 6 apical holosystolic murmur is present. There is no organomegaly, but mild bilateral pitting edema is present. What is the most likely cause of this patient's symptoms?
Mm-hmm. Hello, waiting.
Intermittent upper airway collapse. Intermittent upper airway collapse.
Okay, intermittent. So That means what?
Obstructive sleep
Sleep
apnea.
apnea. Okay, that's good. There's BMI 34, so that means that this person is obese. What else? Yeah, because the person is choking and falling back to sleep. That's it. He's fatigued. Falls asleep when reading books and watching TV. So that means that the person is sleeping during the day, right? You can see. So
Mm-hmm.
everything is in keeping. So if you want to do the stop bank now, what's going to be the score? So does he
Um,
snore?
age greater than, yeah, it's more than 3. Is a man, age greater than 50 years old. He's
Okay.
choking. That's already 3. Then BMI.
Yeah. He's snore. He's tired. Is it tired? He's fatigue. Yeah. So we have a lot of
Yeah.
and he's hypertensive. He choked. In fact, oh my
Can
god,
get all this.
he has everything. So okay, what about the next one?
A 50-year-old man comes to the emergency department after a motor vehicle collision. The patient was driving to the office in the morning when he fell asleep at a stop sign. His car rolled into an intersection and a vehicle collided with his at low speed. The airbags did not deploy, but his coffee cup tipped over and spilled onto his right thigh. The patient reports that he slept 8 hours last night, which is typical, and he usually drinks a cup of coffee on the way to work to help him wake up. Medical history includes hypertension. He works during the days at an accounting firm and lives alone with his cat. The patient does not use tobacco but drinks 1 or 2 beers on weekends. BP is high, pulse is normal, respirations are normal, BMI is 36. The patient is alert and oriented. Physical examination reveals only a small first degree burn on the right thigh. The lungs are clear to auscultation and heart sounds are regular with no murmurs. Neurologic examination is normal. Which of the following is the most appropriate next step in management of this patient? The sleep test, polysomnography.
Yeah.
Yeah.
So what's our diagnosis? Obstructive pulmonary B?
Mm-hmm.
Yeah.
I don't have any question on that. And I think I
That's okay.
okay. There's one here. Okay. Let's check this.
A 47-year-old man is evaluated for progressively worsening dyspnea and exertion for several months. The patient has frequent awakenings at night due to choking sensation and feels tired all the time, limiting his physical activity. He does not use tobacco, alcohol, or illicit drugs. Blood pressure is high, pulse is normal, BMI is 48. Jugular venous pressure is difficult to access due to neck fat. Heart sounds are distant with no murmurs or gallops. Bilateral breath sounds are normal with no crackles or wheezes. Trace bilateral pitting edema is present. Chest X-ray reveals poor inspiratory effort but clear lung field. Which of the following additional findings is most likely present in this patient? Um, decreased PCO2 due to persistent hypoxia.
Please, I'm giving you guys time to check. Oh. Please check it. Oh.
Easy. Mm. Oh God. The patient has ulcer.
Yeah,
Sure. Also
erythropoietin no, not be
pressure,
low.
respiratory effort,
Everything be high. Erythropoietin.
What? So if
increase BUL.
ha,
But already having heart
I
failure.
know what is happening. We are all tired. That's the problem.
Alaka pitting edema is present
The problem
because of
now
the heart
is that we are
jugular
all
venous
tired.
pressure. Yes,
This
we are honestly
this patient
diminishing
has
return.
This patient has obstructive sleep apnea, right? And
Yes.
what do you expect for the PCO2 level?
It will
Because
be
they
high.
told
To be
us
low.
they told us that
It will,
this person has chest X-ray reveals poor inspiratory effort. This is already talking about
yeah.
probably this person has hypoventilation. So with the obstructive
Yes.
sleep apnea. Okay. So if the person is
Mm.
hypoventilating, what do you think will happen to the PCO2 more than
It it will be
To be
high.
low.
yeah. So how do you think the body will compensate for that?
Sorry.
Hyperventilation.
The PCO2
Hyperventilation.
is high.
Yeah, PCO2 is high.
Hyperventilation. The body will compensate with
No,
hyperventilation.
now why would the body compare with hyperventilation to Antonia?
I'm
If
confused. Please,
PCO2
why
is
is the
high,
PCO2
we said
high?
if PCO2 is high.
Okay, wait, let me take it again. This person has hypoventilation, obesity hypoventilation syndrome, right? Now,
Mm-hmm.
with obstructive sleep apnea. So, this
Mm-hmm.
person is going to be hypoventilating, right? What will happen to the
Mm-hmm.
Yes.
Mm-hmm.
PCO2?
Okay, it will
It will
be
be
high.
Now, how will the body compensate?
oh by carbonate retention.
By carbon retention. So, what will happen to chloride level? The body will.
Yeah, we are tired.
So, that is what I'm saying. I don't know. I don't know how
Oh
the urban does
gosh.
this, but this stuff is crazy. I mean,
Respiratory system is something else, so honestly.
ah, ah, but is respiratory system more than all these neuro and the likes?
Dr. Babarinde doesn't
Neuro,
really,
neuro, neuro is
it doesn't
neuro is
read.
just straightforward.
Oh, he just give you the point and he moves. And the only reason,
Yeah.
the reason is because when I did my initial recipe teaching, I did not solve questions. So that was what I'm saying. Like,
Yes.
okay, I just need to show people questions this time around. So that's why we are kind of a little bit slow. But let's still go on. Let's just manage. We're almost done. We are just some few slides out. So
And that
the
it
what?
was a little bit difficult. So this
The what? Hello?
no, he said
Dr.
that the
Anthony, your network
questions
was
is really
breaking.
yeah. I said the questions you're solving is really helping because the first time we did it, there was no question. It was a little bit hard grabbing all
Yeah,
this.
it's going
You
to
were
be
even
hard.
really down.
That was why I was trying to look for the
Yeah.
questions. So that's why I don't want to shy away from it. So it's because you're going to drive
Mm.
home some of those points. And question is going to expose you to some things that you have not even said. So yeah, so let's move to, so don't forget about the management, please. Just go and solve questions to attack more of these things. So don't forget your CPAP, don't forget your BiPAP. Don't forget when you use them. It's
Mm-hmm.
important, very important. Look for more question on OHS. So for rhinitis is just very similar to sinusitis. Like both of them they exist together. So similar symptoms, nasal congestion, the sneezing, the itching. But here you are not going to be having facial pain. That's just it. And you have two different types. You have the allergic and the non-allergic. So for the allergic rhinitis, you're going to be having the rhinorrhea, the nasal congestion, the sneezing, the itchiness, and of course you are going to see other features of allergic problems: asthma, allergic conjunctivitis, dermatitis, and the likes. And it's going to be following a particular time. It is a type 1 hypersensitivity, we know that, IG mediated, and it follows like three patterns. It could be intermittent or seasonal, particularly during the winter period when the pollen starts growing and the trees and grass, you know, then the pollen can, be inhaled, leading to the allergic rhinitis. So that occurs during a particular time, summer and spring, when everything is, the plant has, sprouting and they are growing. So why the persistent one occurs every time? Because the antigens are with you every time. House dust, dust mite, mold, dog, cat, fur, and the likes. Then some people get it when they get exposed to some certain food. So that's allergic rhinitis. Just don't forget that you are going to get history of other atopic disease, so that should heighten your suspicion. The diagnosis is clinical, right? You observe your nose, you're going to see nasal congestion, pale boggy nasal mucosa with hypertrophic turbinate. So that talks about the nasal congestion. And if you do your skin prick test, you are going to observe reaction to the allergens. So that can help you identify if you do your total serum IgE is going to be elevated. If you do your RAS, you can also look for specific IgE to the antigen. So your RAS is just going to identify your IgE to specific allergen. That is not very high. You don't waste your time. You know, just know that the treatment is just avoiding the allergen and the medications. Now, what I'm going to say here is that for allergic rhinitis, what you do is that you give them oral antihistamine, which are non-sedating, and you give intranasal steroids. For the other ones, you give intranasal antihistamine, intranasal steroids. But for allergic rhinitis, you give oral non-sedating antihistamine like loratadine, cetirizine, fexofenadine, and you can give your intranasal steroid with it like fluticasone and the other ones. Yeah, and sometimes you can also add montelukast because of the asthma and the like to control the asthmatic symptoms. If all these ones fail, what do? Give immunotherapy, which is more like desensitization. You gradually be exposing them to the allergen until they become used to it. Very simple. For the non-allergic, it is not related to any allergic process. So we have different types. It could be irritant. Maybe
I
the
think
person.
I need it.
Hello.
Sorry. I said I think I need it. No, I said I think I need immunotherapy.
Oh, immunotherapy for what?
The
Okay, is it for your
immunotherapy.
nose? Are you having allergic? Your own is not allergic.
Yeah,
Is your own allergic?
yeah, my allergy. I have it almost around the year.
Oh, okay. Have you tried using the non-sedating loratadine 10 milligram?
I'm on it almost every day. As
Ah, wow.
though they gave me the nasal
Okay,
steroids
steroids.
and those,
Okay,
but
okay.
I'm not compliant at any of them.
Ah,
I'm
you
not
see, you see, that's it. That's the problem. You have to be compliant with it. Most doctors are not compliant with medications. I think we should do a study on that. Compliance of doctors to treatment and blah blah blah. We are going to find interesting results. Yeah. So non-allergic rhinitis, etiology, irritants, smoking, pollutants, different things that can irritate. A lot of stuff. Fumes. It could be vasomotor. Probably the person get exposed to dry hair, which is cold, or temperature changes, or whatever thing is going to cause vasomotor. This one is just increased blood flow to the nasal mucosa. That's all. Gastritis is when the person eats some spicy foods, and everywhere the nose started running. I don't know some spicy food that can cause it. Maybe eat hot jollof rice that is very sweet with a lot of pepper.
hot sauce.
Hot, hot, hot sauce. Yeah. So spicy food cause respiratory rhinitis. Drug induced. So most of the ACE inhibitors, the NSAIDs, the antihypertensive, they cannot cause the drug induced. The hormonal occurs in pregnancy. So the pathophysiology is not very clear, but it's been shown that the hormones during pregnancy can, increase blood flow, which could cause rhinitis. And people of older age can also have atopic rhinitis, in which their nasal gland fails to function adequately. There's evidence of atrophy and sclerosis. So, that's that about the senile rhinitis. So, taking them again, irritants, smokes, perfumes, occupational exposure, maybe some chemicals, vasomotor, probably cold hair. Temperature changes, is result for the vasomotor, and there's increased blood flow. Gustatory is food, drug induced, beta blockers, NSAID, ACE inhibitors, cocaine, hormonal pregnancy, senile old people. That's all. So what do you do? Avoid any precipitating factors you can lay your hands on. If a person is using drug, tell the person to stop. Cold, avoid cold hair. Smoking, stop smoking. Occupation, change your occupation. Then you now start instituting your treatment. Don't forget, we said for the allergic rhinitis, what do? You give your oral non-sedating antihistamine, right? So
Yes, and intranasal corticosteroids.
exactly. So here you give both intranasal corticosteroids, intranasal antihistamine, and the antihistamine you are using here is actually sedating. Azelastine. So azelastine is sedating. It's a first generation, and you give your intranasal, right? Um, Sometimes you might need to give intranasal anticholinergics like ipratropium because um the the what's it called? The secretory component of it is very common in the gustatory. So gustatory one is more associated with the parasympathetic activation. So that means you might need to give them anticholinergics, to stop their rhinorrhea. Then you can also help with the congestion by giving the congestant like phenylephrine and oxymetazoline. So that's that. Most of the time, the question will not go beyond your intranasal antihistamine, trust me, and your intranasal corticosteroids. You will see. But then I don't have a question, so um, but that is that. So nasal polyps. So nasal polyps are just like benign growth within the nasal mucosa. So most of the time, what I want you to have at the back of your mind is once you see nasal polyp, know that the growth is actually bilateral. If it's not bilateral,
Hello? Is anybody hearing him or is it only me?
I can't hear him. Let me text him.
I sent him a text.
hello,
Chief, we didn't hear you for like 5 minutes.
5 minutes, okay. Ha.
It's true.
Did you hear when I talked about the polyps?
Yeah, we
Yeah.
always thought that is bilateral. It's usually bilateral.
Okay, that's not up to 5 minutes now. So nasal polyps, bilateral. And I said they are like benign outgrowth of the what's it called? The nasal mucosa, and they are shared with chronic processes like individuals having chronic infections, cystic fibrosis, then the SAMSA triad of the chronic rhinosinusitis. Dr. Antonia, are you there? You
Yes.
see, once you don't hear me, just say you are not hearing me. Like me, I can hear you guys. So once you cannot hear me, I'll just adjust my speaker and you hear me. Don't wait so that I will not expend too much energy. Yeah. So um yeah, so they are going to be having bilateral nasal obstruction. They are going to be having post-nasal discharge, congestion, sneezing. All these things are non-specific. But what is going to raise your suspicion is when you have the bilateral nasal obstruction. Bilateral word. That bilateral is important. And the fact that it is associated with the Samsung triad. I've said it. If you remember the Samsung triad, uh, aspirin allergy, chronic
Allergy.
rhinosinusitis with polyps. That is the way it's been put. Chronic rhinosinusitis with polyps, asthma, and aspirin allergy. How do you make your diagnosis? So, um, most of the time you can just do your endoscopy in clinic, or else you can do your coronal CT scan. You are going to identify the polyps, and if they appear atypical, for example, if they are unilateral, you can take off papilloma, then you need to biopsy. Or if you give them the drugs, oral steroid, and it does not respond, you have to biopsy. So how do you treat polyps? Please never make that mistake of going for surgical removal first. Polyps is treated with oral corticosteroid. In fact, they are the most effective. Then your intranasal corticosteroids are less effective. Give oral corticosteroids. Then if the symptom is very severe or it's not responding to medication, then you go and do surgical removal, polypectomy. You also need to treat the underlying cause. Probably the person has allergic rhinitis causing chronic rhinosinusitis, cystic fibrosis, you have to manage it. Please, do we understand the nasal polyps?
Yes.
Moving on to
Yes.
epistasis. Epistasis is another thing that we need to know, you know. Uh, and this is just bleeding from the nose. It can be anterior or posterior. Now, most of the bleeding is anterior, and they bleed from the Keseba plexus. We are already familiar with this. What's the Keseba plexus made up of? We'll call it the little area of the nose. The acronym is the legs, L-E-G-S, legs. The L for the labial artery, the superior labial artery from the facial artery, the E for the anterior edgemotor artery, the G for the greater sphincter artery, the S for the sphenopalatine artery. You cannot forget this artery. I beg you, please and please. Sphenopalatine artery, because it's important both in the anterior and the posterior. Now, S for the L for the labial artery from the facial artery, E for the anterior ethmoidal, G for the greater palatine, S for the sphenopalatine. Then the posterior epistaxis occurs due to bleeding from the sphenopalatine artery. The sphenopalatine artery, the posterolateral branch of the sphenopalatine artery, and sometimes the carotid artery. Now, let us now look at the causes. Very easy. You don't need to cram or anything. The person has facial trauma, person sniffing drugs, hair, dry nose, constant nose picking, foreign body tumor like nasopharyngeal carcinoma. All those things can cause epistaxis. Or hypertension. We remember hypertension. People with vascular malformation in the nose, hemangioma. Anybody that is on antiplatelet, anticoagulant, all those things can all cause epistaxis. How do you treat? That's where they will now be waiting for you. Now, what do you want to do? The first thing is you want to see ABCD, right? If the person is having respiratory difficulty, hemodynamic instability, what do you want to do? ABCD resuscitation, right? Very easy. If the person is then while you are doing your ABCD, you are collecting samples for your coagulation studies, full blood count, blah blah, and the likes. But if the person is not having hemodynamic compromise or any respiratory problems, and the person is much more stable, what do you want to do? You want to do ABC and take a look. ABC and take a look. So this is the acronym I kind of carved out for initial conservative treatment. ABC and take a look. So what are you doing for the A? You are trying to lift the body above. Take the body above. So elevate the body. Is it somewhere here? Elevate the body and tilt the head forward so that you don't allow if you push the head backwards, the person has a very high chance of making the blood run backwards, and the person can aspirate the blood. So tilt the head forward and elevate the body so the person can drain the blood outwards. That's the positioning. Your B is applying a bilateral pressure. So you apply bilateral nasal pressure and you apply a topical vasoconstrictor like oxymetazoline or lidocaine, and you pinch the nose bilaterally. Then the C is you now applying cold compress. Please, mind you, in the exam, it's not necessary you find all these things, but anyone you find there, you pick it. Elevate the body, bend it forward, bilateral pinching, administer your vasoconstrictors like your lidocaine or your oxymetazoline, cold compress, then take a look. What are you doing to take a look? You can use your speculum or you can use your rhinoscopy. Then you take a look to see where the bleeding is coming from. Is it anterior or posterior? Is it anterior or posterior? Now, if it's anterior, what do? Two things. You can cauterize, then afterwards you can now consider packing. So the first thing you want to do is to cauterize. Once you see that it is anterior, you cauterize. You apply your chemical or your electrical cauterization. Cauterization means you are just burning away that vessel so that it doesn't bleed. So you can apply silver nitrate for chemical, or you can apply electric cauterization. If this fails, you have to pack it. You can pack with ribbon gauze, you can pack with catheter, you can pack with nasal tampons. You pack unilaterally. If it fails, pack bilaterally. Can we see this stepwise approach? ABC, take a look. A, rise above, tilt the head forward. B, bilateral pressure, administer your vasoconstrictor. Your C, code compress. Then you take a look to see where it's coming from. Is it anterior or posterior? If it's anterior, first thing categorize chemical or electrical. Then if that fails, pack one single packing. If one single packing fails, double packing.
We can't hear you.
Chief, we can't hear you. Dr. Babawale, we can't hear you. Hello, Dr. Babawale.
I hate this microphone that I'm using. Please, can we hear me now? I'm not using any microphone again.
Yes.
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 Hello, can we hear me now? Hello? 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 Hello?